So, ladies and gentlemen, we're now going to have two presentations of the abstracts that were considered the best submitted to ICC. And the first is by Dr. Sadat on behalf of Dr. Tom Schwann's group. And that's going to be radial artery multi-arterial coronary artery bypass grafting without calcium channel antagonist is safe. So if we could have our first presenter, please. Oh, thank you.
Thank you. Great. Hi, everyone. I guess officially good afternoon. Thank you for the opportunity to speak. I'm going to be talking to you about our experience using radial arteries and multi-arterial coronary artery bypass grafting without the use of postoperative calcium channel blockers. I have no disclosures. As we all know, any coronary graft, truthfully, is at risk of spasm. You can have a vein graft spasm, the mammary, and also a radial artery. The radial artery is most likely of most concern because in 2021, obviously ACC/AHA guidelines came with the use of oral calcium channel blockers for the first year after using a radial artery. But not all patients can tolerate that. There's different side effects, things like edema, fatigue, hypotension, bradycardia, of course, and certain inabilities to combine the use of these calcium channel blockers with other medications like beta blockers or ACE inhibitors. So there's other anti-spasm strategies that many of us employ, certainly systemic medications, but also, in terms of your technique of harvesting, not only in open, but also endoscopic harvesting, making sure to preserve the endothelium, not over-distending, and just trying your best, of course, in terms of limited touch versus no-touch techniques to really preserve this graft and try to prevent spasm. And of course, topical antispasmodic can be used. And in our practice, we do use all endoscopic harvesting techniques. It's a limited touch technique. And after the radial artery is removed and harvested, we do put it within what we call our conduit bath that's comprised of rapamyl, nitroglycerin, heparin, and sodium bicarbonate. So it sits in this bath up until the point of being used as a bypass graft. So, there's been lots of research in the radial artery and its vasoreactivity. It's been found to be at higher risk of spasm than the mammary, and some of that has to do with really the medial layer and the thickness and lots of things that we've already discussed. And folks in this audience, of course, have been pioneers of doing this type of research and looking at the radial artery and its spasmatic principles. Dr. Gardino has really, even since 2005, looked at many different cases and has had randomized controlled trials looking at this exact point. Now, initially some of the trials looking at one-year outcomes of radial artery in patients that used calcium channel blockers and really didn't show any difference in radial artery patency. I think later on he looked at those group of patients that did get calcium channel blockers for a year and wanted to see if you stopped it. He randomized it in a group of stopping the calcium channel blockers and then continuing it on for 5 years and showed no difference in radial artery patency. But then later on, there was a meta-analysis of 6 randomized controlled trials with over 730 patients that had radial artery grafts, and there was actually a difference 10 years down the line of radial artery patency and also improved clinical outcomes. So, really given the ambiguity of the data and the information regarding the use of calcium channel blockers in radial arteries, we essentially just wanted to look at our own experience with this. And again, we do not routinely use calcium channel blockers in any of our patients. So we were just looking at perioperative outcomes in our multi-arterial graft patients that over a 3-year period from 2018 to 2021 using our own institutional SDS adult cardiac database, and just looking at ODE ratios essentially at operative mortality, stroke, sternal wound infection, renal failure, prolonged vent, and re-exploration. So out of a total of over 1,300 patients that received coronary bypass grafting surgery, 43% of which did receive a radial artery multi-arterial graft surgery. You can see here our demographics. They're youngish patients. Average age is 65, mostly males. And the mean number of grafts somewhere between 3 to 4 vessel cabbages, and most of the time was a IMA to a single target and radial artery to a single target, but sometimes the radial artery would be sequential to a third target, and the vast majority of our cases are in fact on pump. You can see some of the other data, very intraoperative statistics, and postoperatively, about a week in the hospital with a reasonable 30-day readmission rate around 7%. So again, just looking at these outcomes, you can see the mortality, sternal wound infection, prolonged ventilation, stroke, renal failure, and re-exploration are all pretty reasonable, less than 1 ODE ratios. But again, these are 30-day short-term outcome results, but all very acceptable in our experience, in our hands. So with all that being said, our conclusion is that using radial arteries for multi-arterial bypass grafting without postoperative calcium channel blockers is associated with good outcomes and also may be considered safe. But again, these are preliminary and certainly hypothesis generating, and just looking at our own outcomes, given the ambiguity as to whether or not it actually makes a difference. So further studies certainly are warranted to optimize these outcomes. As you may clearly see, there are some limitations to this study. There's no long-term outcomes. We're just looking at 38 perioperative outcomes. We didn't have a control group, and we did not have the perioperative MI data. I can tell you anecdotally, it did not seem to be any different, but that's something we're planning on looking at going into the future and looking at our more longer-term data. So thank you all very much for your attention, and welcome any questions.
So a very interesting and rather provocative presentation from a group that cares about and has cared about radial artery grafting for a very long time. So thank you for bringing that to ICC. Now, there has been a dogma. There has been a dogma. Yep. Oh, there's been a dogma that we should. That one works. There has been a dogma that arterial grafting, especially radial arterial grafting, requires systemic vasodilators in order to optimize graft patency and clinical outcomes. And so many of us have been trying to squeeze in a little nitroglycerin or Imdur or oral Isodil or switching to amlodipine. Some practitioners have even been giving IV diltiazem in the recovery room just after surgery. This has been part of the management or the accepted management of radial artery grafts for literally decades. Were we wrong? And has your data impacted the practice at Baystate? Do you or do any of your surgeons use intentionally vasodilators for radial artery grafts at Baystate?
We do not use systemic dilators at all, only that conduit bath of having the treated actual radial artery. So, I think there's just side effects associated with some of that utilization of the systemic antispasmodic and dilators. And I don't think all patients tolerate it, and we've just, again, based on our experience, have not seen a true difference in regards to, increased episodes of spasm.
Now, we have, I was going to ask Dr. Trambaugh to come to the microphone, but he is, as usual, a step ahead of me. Bob Trambaugh has been an advocate and a practitioner of radial grafts for roughly 3 decades, with the benefit of Helbert DeCastro, who's here in the audience, who has for the last few years harvested radial arteries in my OR, but he did that with Bob for about 3 decades. And so, Bob, you've had the opportunity to use really perfectly harvested radial arteries for a very long time. And we're talking about many, many, many hundreds of cases. And you've always used calcium channel blockers to the extent that patients would tolerate them. What do you think about these data? And just give us your perspective on this issue.
Thanks, John, and congratulations for a very nice presentation. And it is a dilemma as what to do with this. And, I've followed Tom's lead on this and have cut back on the number of patients we discharge on calcium channel blockers. In fact, we switched to nitrates a number of years ago after the initial perioperative period. And one of the things I've been really concerned about, it seems like all our patients have vasoplegia and are on high-dose alpha agents. And we run diltiazem intraoperatively and then perioperatively, and then start nitrates once they can take oral. So we haven't quite weaned to know antispasm. But I must say the evidence is confusing. You know, the earlier studies clearly did not support calcium channel blockers. And then this meta-analysis sort of threw that into question, and we're sort of looking for answers. But I must say, intraoperatively and in the immediate perioperative period, I think diltiazem it just makes me feel better with all the vasopressors on board. Do you have any perioperative calcium channel blockers or nitrates at all in your patients?
Nothing. None whatsoever, and lots of vasoactive agents, undeniably, in terms of our patients that come out of the operating room. So I just have not seen spasm. Again, some of this is anecdotal, and obviously this is retrospective over that 3-year period, but you know, with 43% radial artery, we just haven't seen it, which is great.
Well, it's certainly, I guess it was Gunga Din, you're a braver man than I, and I think that you know, I certainly have cut back on the calcium channel blockers and nitrates long term, but perioperatively, I guess I'm just a little gun shy of that and worry about that. On the other hand, in all honesty, the only real episodes of arterial spasm I've seen are in the LIDA. And that can be very dramatic and very life-threatening. I've never had that with any of the radial grafting we've done. Mm-hmm. So I think there's probably something to the not using calcium channel blockers.
So I'd like to hear from Dr. Tom Schwan, who's the senior author on this paper, but I'd also ask Dr. Qian from Fuwai to give your perspective. Tom first, and then Dr. Qian, because you run a much bigger program, and you've been focused on doing no-touch vein as an option. But first, Tom, what are your thoughts on these data? Where does it take us as a field devoted to increasing arterial grafting? And then I'd like to hear what your thoughts are from Beijing.
So thanks very much for the opportunity. Siavash, nice presentation. So again, we just, you know, with this approach, we've gone sort of full circle because when we first started radial artery utilization, we did exactly what Bob was saying. I mean, we started intravenous cardizem infusions for a number of days post-operatively, then we transitioned to PO cardizem. But what we have noticed is that, you know, we were combining both beta blockers as a quality metric with calcium channel blockers, and we would routinely find that the nurses either held one or the other, right? And what we would say, well, the calcium channel blockers were held, or the beta blockers were held, there was blood pressure issues, there were, you know, bradycardia issues. And what we decided to do is do this in a sequential fashion over probably, 5, 6, 7 years. And initially we went with the IV cardizem intraoperatively with no PO cardizem. And then as a next step, we started looking at potentially avoiding intravenous cardizem and not essentially going bare. And we just don't see spasm as a real issue intraoperatively or postoperatively. Now again, when these folks get cathed and they engage the catheter at the ostium, then I think they do get spasm. Whether that's affected or not affected by the presence of either nitrates or calcium channel blockers is unclear. You know, we have put together this bath which has both nitrates and calcium channel blockers, which affect the two sort of pathways that result in intracellular calcium rise, and both of those processes are blocked by that. I don't know how long they last, but we have not seen calcium channel blockers spasm in the perioperative period. I should also point out that there's a nice study by Mario that he actually looked at the transformation of radial arteries that are implanted into the coronary circulation and found that there is a progressive decline in the amount of muscular elements in the media in those patients in whom the radial artery was implanted with coronary circulation. And actually, the propensity for spasm, when he compared the radial arteries that are used as grafts compared to native radial arteries that are still in situ, the spasm capacity was much higher in the radial arteries in the wrist as opposed to the coronary circulation. So there is potentially some sort of mitigation of the potential to spasm, but what drives that over what period of time I think is unclear, and I think that's why a randomized trial would not be unreasonable.
Dr. Tian, what are your thoughts from Beijing?
Yeah, first we have to say that there, from the literature, as we learned, there is no conclusive type of calcium antagonist to prevent the radial artery spasm. Everybody knows that. And the second thing that from the first time I was on I was within the surgery, I've been witnessed the spasm of radial artery graft from time to time. It was very unforgettable because after you complete the distal anastomosis, the flow of the graft was very nice. Yeah, but at the end of the surgery, and the chief surgeon had left the OR, and you rechecked the flow, it was zero. There was no flow. And no matter what they tried, we inject the calcium channel blockers and antagonists directly into the graft, no change. But when patients returned to the ICU unit, and there was hypotension, and there was everything, we tried everything. We tried the norepinephrine, we tried the vasopressin, but the blood pressure remained very low. We've seen that from years. So if you give me an option, I've been waiting to for your presentation because it is really, as Dr. Pascal said, it's provocative, yes. But we dare not to comply with your method because we dare not face that kind of situation. So the third thing, and I want to say that because from your presentation, I don't know, you didn't have the data, or you hide the data from us. What is the flow of the radial graft and compared with the swing graft? And what is the most important thing, that where did you bypass the radial graft, to the left, or the obtuse marginal, or the PDA, or some the right coronary main trunk? Because our senior surgeons from Fuwai Hospital in Beijing told us that, because I'm young, I'm less than 40 years, I have completed less than 100, almost 100 CABG cases myself. If you use a radial graft and you are not confident, you are afraid of vasospasm, you bypass it to the obtuse marginal. That would be safe.
Thank you. Could we have a quick comment from Dr. Tatoulis of the Melbourne group, because they've used a phenomenal number of radial arteries, and how does your practice work?
Thank you very much. We started using them back in '95, probably done over 20,000 radial artery grafts with a lot of angiography. So we found occasionally when we took patients to the cath lab, because they weren't doing well post-op, anecdotally, a few of them actually did have radial artery spasm, despite we either used routinely papaverine or milrinone, and basically it was based on the fact that anecdotally we saw cases with real radial artery spasm which resolved with intragraft nitroglycerin. So we took the approach of why not use it, because unlike what you were saying, I personally have never really seen a patient that couldn't tolerate amlodipine. So our practice is not scientific, it's anecdotal, but it's certainly based on real events that we saw. So we still use them if we can. Obviously, if there's some hypotension or other contrary problems, we stop them. But if we can, the patient tolerates them, which usually is not a problem, we continue to use them.
So in closing, I'll share our own protocol. We will treat patients. Well, first off, I don't believe that one can give a patient a calcium channel blocker and levofed or vasopressin and expect the molecules to go to the right place. The amlodipine or the diltiazem will not go to the radial artery, and the vasopressin only go to the leg. That doesn't happen. The molecules go everywhere. So it makes no sense to me to give a calcium channel blocker or a nitrate if the patient is on intravenous alpha agents. So we try to tank up the patient, give them volume, get them off alpha agents, and maintain a good perfusion pressure. I think hypotension is the biggest threat to arterial grafts. So maintain normotension, or even a little higher than normotension, and then we typically will start nitroglycerin, either as a drip if the patient's hypertensive, or oral Isodil, and then switch to Imdur before they go home. If they happen to be very hypertensive patients, they may go home on Imdur and amlodipine as part of the antihypertensive regimen, which we think will also help the arterial grafts. but they go home on neither if their blood pressure is 90. We want them to go home with a normal blood pressure. I don't want them falling down the stairs. And I think that arteriographs are more patent if they have a good head of pressure. So that's how we've sort of split the difference. Those who can have arterial vasodilators because of their intrinsic hypertension, they do receive those drugs. Never in combination with alpha agents and never at the expense of hypotension. Let's go on to our next. Thank you so much for your presentation. We have one other presentation today in what we think of as some of the more provocative abstracts submitted. And then we'll break and get lunch, which is in boxes outside the doors, and come back for the afternoon session.
Good afternoon, ladies and gentlemen. Dr. Tagat, Dr. Boskas, thank you very much for the invitation again. And the task given to me this time is a little bit different from each other time. I am supposed to talk about the Impella-supported CABG in patients with poor left ventricular function. These are my conflict of interest. As we already know that surgical management of patients with a severely impaired left ventricular function undergoing cardiac surgery is always complicated and associated with a high morbidity and mortality. Mechanical circulatory support using ECMO or ECLAS is the main mechanical circulatory support system for such patients. Recently, the Impella 5.5 has been adopted as a short-term or temporary MCS and gained more adoption in the past couple of years. In our facility, we use Impella 5.5 since 5 years and has been adopted and in different indications. This is a picture of Impella 5.5, and it has been earlier reported from the group in Hamburg, Professor Aschenspur and his team, and later on even the new surgical circulation in the patients with cardiogenic shocks. In CABG in failing heart was also indicated the Impella, and this was reported from Tang in 2021. So even as we reported our early results this year, in April, in International Society of Heart Lung Transplantation using the mechanical circulatory support with the Impella 5.5 in patients with a CABG surgery with a severely impaired left ventricular function. I'm going to discuss 2 cases with you. The first case I have operated since more than 1 year, 1 year and 5 months ago. And the patient is 65 years old, presented with acute coronary syndrome and dyspnea at rest, and he was at the evening presented to the cardio CPU unit. The patient medical history: arterial hypertension, hyperlipidemia, nicotine abuse, and alcohol abuses. The patient has a left-sided brain stem infarction, and he has an event recorded. Emergency coronary angiography showed severely diffuse 3-vessel disease with a chronically occluded LID, and the BCI was not possible. They referred the patient to us, but 12 hours later. The syntax score was calculated to the 40, and these are the coronary vessels in the coronary angiography. We see here the LID is totally occluded and a huge marginal vessel, and the right coronary artery had a severe disease. So I didn't see the patient actually before the procedure because he was transferred immediately to the OR. And he was already intubated in a sort of a cardiogenic shock. He needed inotropics to support him. And when we do a TEE, we have an ejection fraction of 23% with an apical and septal akinesia. So actually, we do a normal surgical setup with using a cardiopulmonary bypass with a median sternotomy. As the patient with a cardiogenic shock, I decided for Lima and veins, and I go with a central cannulation and moderate hypothermia 34 and cardiac arrest with a crystalloid cardioplegia. Sorry, there is sort of technical. Okay. So the patient underwent fear coronary artery bypass grafting with a limit to LAD and the vein to the Rams diagonal and RCX and right coronary artery. And the clamp time was 60 minutes. And after cardiopulmonary bypass, we test the bypass function, left ventricular, right ventricular function, catecholamine, and lactate value. And the patient was already weaned from the cardiopulmonary bypass, but about 15 minutes later during the hemostatic phase, the patient has an elevated lactate with an increase in the catecholamine values. So we decided for a bailout strategy, either vena arterial ECMO or an Impella. And this is our algorithm how to treat such patients. So we start with a transient time flow. We make sure that the patient's bypass are already good, and then we look at the right ventricular function. If it's good, so we look at the lung function. If it's good, to go further. The increased lactate value and catecholamine value lead us to decide for an MCS using the Impella because of the failed left ventricle. And this is the results of the patient. The transient time flow shows the good results with a PI less than 5 and flow more than 30. This is our cutoffs in the OR, but the ventricle was on the left side was still failing and the right side was acceptable. So we decided to go to the Impella 5.5, and we implanted it transaxillary. Afterwards, or during the procedure after this step, I asked about the lab works during admission to the ICU, actually to the OR, and I find out that the patient has a CKMB of 353 and more than 100,000 troponin I. So the patient was in a severe cardiogenic shock because he late admission to us after 12 hours of the incidence of the acute coronary syndrome. The post-operative course was pretty much good. The patient was discharged to the ICU without catecholamines, in a stable hemodynamics and preserved lactate values and good urine output. He didn't even need dialysis. Early reduction of anesthesia, neurological control, early weaning from the ventilator, and second post-operative day was the patient extubated and early mobilized. The Impella weaning started at the 5th post-operative day. We start with using calcium synthesizers and levosimendan, or Simtex as you call it, and we completely remove it at the 7th post-operative day. The patient left the ICU at the 8th post-operative day and the hospital at the 10th post-operative day. 12-month follow-up is uneventful. And these are the x-rays before post-operative immediately and before discharge after removing the Impella. The second case is about 2 months ago. A 69-year-old patient presented to us with a dyspnea and a medical history of arterial hypertension and diabetes. The patient coronary angiography showed severe 3-vessel disease with impaired left ventricular function. Echocardiography shows a mitral valve regurgitation and dilated left ventricle with an ejection fraction of 24. So we go to the surgery. I thought I'm going to repair the mitral valve plus bypasses, so I decide for a Lehman veins and mitral valve repair. But the intraoperative TE showed that mitral valve was not that severely regurgitated. So we had the 4 bypasses and cross clamp time 48 and good machine time. But before cessation of the cardiopulmonary bypass, I completely changed my way of thinking since in the past 2 years between bailout to a protection. So I decided to do a protected cardiac surgery and immediately switch to Impella 5.5. So this is the echocardiography in the OR. You see that the left ventricle is dilated and the mitral valve insufficiency is not that huge, and there is no structural pathology in the mitral valve. So I go for one side clamp and I do proximal and Impella graft anastomosis. I went to transaortic direct Impella implantation, and the patient, and we do always the flow and everything, and I always put the Impella, transaxillary, sometimes transaortic, and these are the results after Impella implantation. The flows were okay and acceptable, more than 70 milliliter for the Lima LAD and almost 200 milliliters for the vein graft. So I didn't have a problem with the grafts this time. Discharge to the ICU without catecholamine support, stable hemodynamics and cardiac output, preserved lactate values as the last patient, good urine output, weaning from the ventilation after 3 hours and mobilization first post-operative day. So Impella weaning started this time at 3rd post-operative day and completely removed at the 5th post-operative day, and ICU discharge at the 6th post-operative day and hospital discharge at the 8th post-operative day. 1 month follow-up. We discussed yesterday that improvement of ejection fraction of patients receiving Impella. I agree with the colleagues when the patient has a valvular lesion, but when he has a coronary lesion, I think the ejection fraction is totally improving. And this is a small video of about 1 minute of the patient after at the 5th post-operative day when we explant the Impella. The patient is completely awake. We just do it under local anesthesia. The procedure takes about 15 minutes. We remove the Embella from the graft after putting it at P0, and then we flush the rest of the graft to avoid any clots into the graft and neurological complications in the future. We cut the graft down and do an additional suturing for the graft. And afterwards, it's a very important thing that at first I put actually the graft as far as away from the sternum. Then I use a betadine to wash the canal and also irrigate the canal with water. And I put some vancomycin locally to avoid any wound infections. So the distance between the graft was delivered out to the sternum is about 7 to 8 centimeters. Patient was still awake and everything went well. So these results of 48 patients until April this year, so I have like a 6-month follow-up, and later on we added like more than 20 more cases, so we are about 70 cases with a protected cardiac surgery. The mean age about 64 years old, and the ejection fraction before implantation of the Embella is about 26 when the patient was presented. Some of the patients came as in a cardiogenic shock with a CPR, like 10% of the patients. And some had a preoperative MCS. Immediately before Embella implantation, the AF was always measured, and it's about 25%. Emergent and salvage procedure was about 45% of the patients. Isolated CABG have been done in 60% of the patients, and isolated non-CABG procedure in 20% of the cases, and concomitant procedure in 20% of the cases. And actually, I tested this because sometimes we discharge the patient to the ICU, and later on he will got an Embella or an MCS. So 70% of the patients had a primary implantation of Embella during the procedure, and some of the patients, 10% had an operative day later on, and after the first or second day in 20% of the patients. So our results are very acceptable. A stroke happens in 6.3% of the patients, and 30-day mortality in 30% of the patients. Switch to a long-term LVADs in 8% of the patients, and successful weaning have been reported in 63% of the patients. After weaning, as I told, in the CABG surgery patients, we immediately see after full revascularization and improvement of the left ventricular function. However, in valvular, it's quite difficult, and thromboembolic complications have been noticed in 6.3% of the patients, and we don't have a local implantation time complications. So to sum up, Embella can be providing support for patients with a failing left ventricular function. We can do a transaxillary Embella like as an additional procedure. We can also just do in a cardiogenic shock, so-called ecmella or ecpella, as you call it, like a Y graft you see here, the thorax is still native. And with the patient, you can also do a direct transaortic. You can also do the minimal invasive before LVAD when the patient is still young. And we can also do a combined ecmella in patients with a very small vessels. These patients come to us from Netherlands, and it was the third patient to come to us from the Netherlands for the same therapy. So our post-operative outcome, we can use CABG and mitral valve repair plus Embella. All these patients have been pictured in the same day after procedure at afternoon. CABG plus Embella, it's possible also. You can do a CABG and MAZE, and also LR occlusion and Embella. You can also do a CABG and AVR and Embella. And finally, you can do it pre-LVAD in a small incision. It depends on where. So we were eligible to be included for the IMPACT EU, and we successfully implant our first and enrolled our first patient for the European IMPACT study 2 weeks ago. So my take-homes. Decision to make MCS, to perform MCS immediately when indicated. Don't wait so long. Evaluate the right ventricle function and the lung function. Do not underestimate that. If only left ventricular function impaired, I use Impella. If biventricular, I use veno-atrial ECMO or even ECMELA. It depends if the ventricle is very dilated and you need to deload it. If the left ventricle function, lung function are impaired, so I do an Impella plus veno-venous ECMO. And very important in CABG patients, if you have a graft failure, don't swallow your ego and do a bypass revision. To conclude, outcomes of patients with undergoing high-risk cardiac surgery, as usual, report high morbidity and mortality as expected by the risk scores. In patients with severe ischemic heart diseases, complete myocardial revascularization is essential for these patients to allow cardiac function recovery. Transaxillary or even transaortic MCS using Impella 5.5 is a feasible and reproducible. 2 of my fellows are doing it now comfortably. Strategy as a bridge for therapy or long-term assist device, immediate hemodynamic stability and early weaning from ventilator and fast mobilization can be achieved. Impella-related complications in our series, I told you like I have almost 70 patients now, are so far fully observed. Meticulous post-operative management. This is a mandatory thing to early detect and treat Impella-related complications. Further study evaluating large cohorts, comparing Impellas with other MCS systems are required to provide reliable data. Thank you very much for your attention.
So thank you for that very nice presentation. Did you now say you've done 70 patients?
Almost 70 cases.
Is that the biggest series? Is this must be one of the largest series of using the Impella?
Yes.
Yeah. So if I understood your figures correctly, the mean ejection fraction was around 26% pre-op, and post-op went up to about 29%. So a little bit of improvement. So what is your winning strategy for the Impella in the post-operative period, please?
Thank you very much, Dr. Taga. This is a very important question, actually. As I already said, we heard yesterday from all our colleagues, the experts for Impella, and we heard that patients undergoing cardiac surgery and Impella, they did not improve the left ventricular function. I respectfully disagree because the patient with a valvular lesion, only isolate the valvular lesion, that will never improve, at least in the small time, 5 to 7 days. But patients undergoing CABG surgery and have severe atherosclerosis of the coronaries, they improve within time. So we start our program with calcium sensitizers at the first. First of all, we have to stabilize the patient. This is the first important thing for these patients. And after 5 to 7 days, we do an everyday echocardiography. We use a Swan Ganz on most of the patients. And echocardiography and assessment of the left ventricular function is a daily. Urine output is a very important thing as well. And other functions like liver and kidney enzymes are very important. And when we see that the patients start to wean, we start from down from B8 to B6, and every day, like more and more. But we use a levosimendan, calcium synthesizer, at the day when we decide to wean and explant 1 day before.
Thank you.
Have you had to replace them when you take it out? If you take out the Impella, on let's just say day 5 or day 6, the ejection fraction is maybe a little better, but maybe 2 or 3% better. You've decided it's time to take out the Impella. Do you always get it right, or do you find yourself putting back in a balloon pump or doing something else to support a patient after removing your Impella?
Perfect question. Thank you very much. As I already mentioned that a lot of patients receive an LVAD. So these patients, when they are not in cardiogenic shock, like this patient, the first case I presented, so I have the time to talk with them. So from the primary, we talk to the patient and consent them for a temporary MCS, and in the same setting, long-term MCS. So if we see that after 5 or 7 days, that echocardiography shows that the patient, and we actually pull down the Impella support from B8 to B2 and do the echocardiography, and you see that the heart is still failing, and there is no hope for these patients, and they are still young and eligible to implant an LVAD, so we do it. Some patients, we have to be fair with it. We explant after 4 to 6 weeks, and they don't have any more support because they are 73 or something like that, so they are not eligible for long-term LVADs. So this is a strategy we have. But so far, according to the series we have, I didn't have to re-implant Impella, the same situation.
From our floor mic.
Alexander Assmann from Düsseldorf. Thank you very much for sharing this data. I completely agree that Impella is a game changer for cardiac surgery in order to improve the treatment of patients with severely impaired left ventricular function and also in complicated cardiosurgical cases. For me, the most important point that you made is you have to initiate MCS as early as possible in the OR, not trying to get it to the ICU and then seeing, okay, he's in bad condition, let's start MCS. That's too late. You've shown that 70% of your patients get it intraoperatively. That's good. Have you comparatively evaluated the outcome of your patients in these subgroups? Probably you have. And
thank you very much. It's a very good question.
Very much support your conclusion.
I'm going. Actually, there's through articles are going to be written about a separate subject about this, and we are considering to evaluate that regarding to multi-organ failure and stuff like this. But it's a very important question. The thing is, I changed my kind of thinking. Earlier, I said like I will wean the bypass and saw what happens, and now I decided for protected cardiac surgery. So when the patient has a cutoff 25%, I usually don't think a lot, but I'm going to immediately do the statistics in this regard. Even we have a small portion of the patients, they have it later.
Yeah, that's good data that we need because we very strictly have to do it as early as possible. Otherwise, we will have very bad reputation for MCS.
Thank you very much. Thank you.